Our next topic is resuscitation of COVID-19 patients, and in particular sort of unique differences of this patient population. Our speaker is Jean-Marc Tadier. Jean-Marc?
Yep, so thank you for giving me the opportunity to share our ideas and experience with the ICU management of COVID-induced ARDS patients. So my name is Jean-Marc Tadier. I'm the head of the Department of Medicine. I'm used to work in the medical intensive care unit from Rennes Hospital. So first, as you know, there is no evidence-based guidelines to take care or to try to heal these specific patients. But I'm going to try to answer the questions. How is resuscitation different from other patients who are admitted to our ICU with sepsis or ARDS? So around 15% from patients with COVID will be classified as severe patients, which means that there is a respiratory rate above 30 per minute and needs for oxygen supplementation. And then among these patients, like maybe 10% of these patients will be classified as critical, and both patients, severe and critical, will need ICU admissions. So the main point is that ICU admission has to be dependent of the severity of illness and not dependent on the ICU capacity. And that's the first point, because it's very difficult, my point of view, to draw any definitive conclusion from the Chinese or from the experiences from Italy, because in Italy, for instance, ICU capacities has been overwhelmed and by coronavirus patients, and there is no guidelines from this experience that we can take. So for us, because we had time to take care of these patients, respiratory failure from COVID pneumonia should be managed exactly as the same way that you manage a severe community-acquired pneumonia. Then we can go for the next slide, please. And the ventilatory management from this patient, I mean, patient from moderate to severe ARDS, in intubated patients should be managed as recommended, which means using a low tidal volume, and try to target plateau pressures below 30 centimeters of water using a PEEP strategy. You can use prone ventilation for at least maybe 12 to 16 hours and use continuous NMDA infusion at least for 48 hours. You can use non-invasive ventilation in COPD patients. That, for me, only for COPD patients. You can use also oxygen therapy using high flow nasal cannula in hypocapnic patients. Not for me, it's kind of dangerous way to try to deliver oxygen to patients who actually are normocapnic or hypercapnic. I think that it's going to increase your mortality, because you have to remind that the high respiratory rates in this kind of patient will dramatically increase lung injury, you know, the concept of self-inflicted lung injury. And as I told you, there is no evidence-based guidelines, but it appears from the experience from Italy that maybe ARDS patients are not typical ARDS. There is a huge dissociation, a huge discrepancy between the preserved lung mechanics with normal compliance and the severity of hypoxemia in this patient. So maybe we should use a lower PEEP level. That's what we do now. The PEEP level maximum is around maybe 10 to 12, but no more. And because we don't, as we saw, we don't have to have a huge impact of the venous return that may induce acute kidney injury. And we also saw that you had a decreased compliance in patients who actually were treated using non-invasive ventilation. So this is a typical management from ARDS patient with ventilatory support. For sepsis, you have to know that maybe roughly 30% of patients After ICU admission, we'll meet the sepsis criteria. The main point is that maybe sepsis is due to acquired infection because these patients are really immunodepressed or immunosuppressed regarding, for instance, the deep lymphopenia, which is going to be persistent. And I will talk about it later, but when taking care of sepsis, usually you have to follow the guidelines using norepinephrine, steroid, and you have to be cautious with your fluid strategy. You have to find the right way to between the conservative strategy over a liberal strategy, because you have to remind that your patients are actually ARDS patients. But what I wanted to show you is that maybe these patients, when we talk about sepsis in COVID patients, are the same patients that septic patients with suffering from deep immunosuppressions, which is going to induce late mortality. And when you have patients we meet shock criteria, you have really to track the super infection. I mean, bacteria, but also aspergillus and maybe virus reactivation such as herpes or CMV. You can move to the next slide. I try to be quick. And as a conclusion, I just want to remind you that maybe there is some kind of typical features in this kind of patients. The story of COVID pneumonia will start at home, then in a ward. And between the 7th or the 10th days, the patient will require so much oxygen that you have to transfer this patient in ICU. And then if we meet the shock criteria, you have to track the nosocomial infection. And there is some kind of particularity in these patients that weaning from mechanical ventilation may be delayed by the encephalopathy. And I invite you to read, there is a nice paper in the New England Journal of Medicine from yesterday. It's a report from the Strasbourg team. It's East part of France about COVID associated encephalopathy in ICU patients. You have also a high frequency of ICU acquired weakness because you are using sedation for a long time and neuromuscular blockade agents. You have when you try to wean patients from mechanical ventilation, we have sometimes hypoxemia. We're gonna delay it really for a long time the weaning from mechanical ventilation. And be aware that because there is some kind of risk factors such as higher body mass index, maybe your patient's gonna have a post-extubation stridor that's gonna require steroid treatments or tracheotomy. And as I told you, you have to track nosocomial infection to avoid the late mortality in this patient, because as the first report shows us that the mortality of the patient from COVID outbreak will die not within the 2 or 3 first days after ICU admission, but mostly after 2 weeks of hospitalization. I'm done. Thank you.